Okay, well, welcome everybody to this version of the CaTS COVID-19 Chronicle Seminar series. I'm delighted to introduce Dr. Patty Kissinger, who will be our guest lecturer today. Just some housekeeping announcements, very brief. During Dr. Kissinger's talk, please type your questions in the chat window, and then these will be saved. These questions will be saved at the end to share your questions with the speaker. So it gives me great pleasure to introduce my colleague and friend, Dr. Patty Kissinger, who I've probably known for nearly 30 years here at Tulane. She is an extraordinary epidemiologist and nurse with over 3 decades of experience in the study of clinical and behavioral aspects of infectious diseases, focusing on underserved populations. Dr. Kissinger, let me just get this thing out of the way here. Received 2 R21 awards to examine HIV, STI, and substance use risk among Latino migrants who came to New Orleans post-Katrina, and is presently the site PI of 3 COVID-19 Gates-funded randomized trials to examine repurposed drugs for prevention or treatment of COVID-19, including our old favorite hydroxychloroquine for post-exposure prophylaxis, or hydroxychloroquine with or without azithromycin, and as well as lopinavir, ritonavir, the HIV antiretroviral regimen. She's also the site PI for the COVID-19 prevalence and antibody population-based study in New Orleans and Jefferson parishes, which is very important in order to try to determine what sort of progress we're making, of course, towards herd immunity. Her team is also examining the influence of the shutdown on sexual behavior among our NIH-funded cohort of young Black men in New Orleans. So without further ado, I'm going to turn it over to Dr. Kissinger, whose topic is research in the time of COVID, building the plane as you were flying it. Patty, take it away.
Thank you so much, David. Appreciate that nice introduction, and thanks everybody for attending this talk. So yeah, I'm not going to talk as much about the outcome of the study because I think everybody knows what happened with hydroxychloroquine, but I just want to talk about the procedure and just kind of all what happened throughout this. We're coming on that. We have now, I think today is the year anniversary of us determining that it's a pandemic. So my objectives of this talk today are to talk about why this time was so chaotic for researchers. It was chaotic for everybody, but researchers also had their share of difficulties. And I'm going to talk about the methods used to do the study of these repurposed drugs during a pandemic. We had 2 Gates-funded studies. One was a post-exposure prophylaxis study, and the other one was a treatment study where we were using several different treatments that we were looking at. And then as Dr. Mushatt mentioned, we were also doing the COMPASS, which is a NIH co-VPN study to look at the prevalence of infection in the community here in Orleans and Jefferson Parish. So we know that COVID was a perfect storm. Of course, airborne, aerosolized. I'm used to working in sexually transmitted infections, and you have to do something different to get those infections. But airborne, just about everybody's exposed. No population immunity. 80% have no symptoms or mild symptoms. Infectiousness occurred in the pre-symptomatic phase, so that's a really dangerous scenario. At the point when the pandemic was first starting, we had no vaccine, no treatment, and most importantly, no coordinated control, no coordinated message that could help people. So we all know that it started in Wuhan, China, and by January 21st, we had a case here in the United States, and at that time, it just fulminated. And so now, 14 months later, we have over 118 million cases and 2.6 million deaths. So you all know this because you've seen this throughout the literature. And just how confusing everything always was. So the first message was don't wear masks, then wear masks. And now they're saying don't wear masks. So at first they were saying, no, don't wear masks, and largely because they didn't want people to take masks away from healthcare providers who desperately needed them. And then they said, wear masks, but the type of masks, they didn't tell us which kind to wear. And now that we're getting the vaccine, they're saying, if everybody's vaccinated, you can stop wearing a mask. Now, I don't know about you, but I'm still a little hesitant on that. I'm still wearing my masks, but whatever. And why didn't they tell us to not? As I mentioned, people were hoarding PPE. They, providers, healthcare workers had to use, in some dire situations, had to use garbage bags to cover themselves up. They were reusing masks that were N95 that were single use only. And then they were telling us, don't use a surgical mask, don't use a surgical mask. You can wear a bandana, don't wear a bandana. So just everything was so confusing. And this is the background in which we were developing this study. And then, as you know, mask restrictions were left up to the states. So that was a common thing. So much of this control has been so chaotic. And you can see that, it's left up to the states, and there are many states that have no restrictions at all, including Florida, which this is a picture from about 3 days ago at Fort Lauderdale. So how many masks are those kids wearing? I don't see any. So yeah, and of course the epidemic continued to fulminate, and we saw after Thanksgiving, we saw a huge outbreak, coincidental with possibly Thanksgiving, but also coincidental with potential introduction of variants that were much more aggressive or much more infectious. And you can see on the right-hand side where, the map is getting lighter and lighter, which is really nice in Louisiana, but we still have pockets of really high infection rates. And so we're starting to lift some more restrictions, and it'll be very interesting to see what happens as we continue to lift those restrictions. And, whether this peak up, this is of course a global epidemic, we're seeing a peak up. Is that going to continue? We hope not, particularly here in the United States as we get more and more people vaccinated. And as you've seen, everything was so fast and furious. It was just incredible. So to get a vaccine for the avian or bird flu, that took, what is that now, about 15 years? And COVID, they did it in like, I think it was like 10 months or 12 months. So really, really quickly, they were able to get a vaccine. And now we have several, 5, I think 4 or 5 vaccines, three that are used in the United States. And so, but everything is so quick and so rapid that it was really hard to figure out how to do these things under these conditions where people themselves were some people were getting sick. Some of the researchers got COVID. Some of the researchers, they had to take care of their kids who were at home and everything. So very difficult. And we're seeing now vaccines become more available, which is really great. And so that's the first person that got vaccinated, but we're also seeing vaccine hesitancy. So that's another thing. It's the population. When the population, even though the scientists say one thing, the population doesn't always follow in turn. And so it is really important to get the population and the scientists in sync. So, and there's conflicts, there are forces that intervene that don't understand or don't care, or it's in conflict with their beliefs. And so, for example, everybody's super happy when Johnson & Johnson got the single dose vaccine out. And then about a couple of days later, a bishop said, oh no, Catholics shouldn't take the Johnson & Johnson because it was derived from fetal cells, which is, a remnant of abortion or a byproduct of abortion. And so you have all these political things in play. And so now I'm going to talk to you about the wild roller coaster we went on. And I'm sure Dave, Dr. Mushatt can add in things because he just did a talk on a similar topic, but this is real. I lived through this. So this is really hard. So I know everybody's got sort of a visceral feeling when you even hear the term hydroxychloroquine. Just feel yourself think about hydroxychloroquine. It makes everybody mad. But really what happened in the very beginning when we didn't know how to treat this. No, scientists didn't know how to treat this infection. They were looking for repurposed drugs, which is often what is done in the beginning of whenever an illness is found. It's a new novel illness. They try to go for repurposed drugs. And there's a good reason for it, is because they're readily available. There's usually years of safety data on it. In the case of hydroxychloroquine, it's very inexpensive. And so that's why there was some good practical reasons to go for these repurposed drugs. There's also a proposed mechanism. Both chloroquine and hydroxychloroquine are weak bases, and they're known to elevate the pH of intracellular organisms. And so essentially that could potentially reduce their infectiousness. And also the possibility that hydroxychloroquine could inhibit entry into by changing the glycosylation of the ACE2 receptor and protein. And that was the rationale for PEP, for the post-exposure prophylaxis study that we were doing. So we're doing two, a treatment study and a post-exposure prophylaxis study. So the PI of the PEP study was Ruan Barnabas, and the PI of the treatment study, the overall PI was Christine Johnston. Both of them, by the way, are STD researchers or HIV researchers. So, you know, we all got kidnapped into this thing, and we're working on it. So, but there was indeed some proof of concept. So when we actually embarked upon this study, and, you know, they started this thing, we found out about the infection in the end of December, and they had already written the protocols, solicited the money from Gates Foundation, and got the drug all within about 2.5 months, which is pretty incredible. But there was good basic science data that demonstrated some potential possibility that chloroquine and hydroxychloroquine, a close relative, could actually have some impact. And there was actually even some studies in humans that showed some promise. And so it wasn't without some scientific backing that they did these studies. So again, we had actually 3 studies. Really, the second and third were the same study. Well, they're all the same study designed, kind of, but we just changed the treatment that we were looking at. So the first study was the hydroxychloroquine versus placebo for post-exposure prophylaxis. So that is people that had been incredibly exposed to COVID-19 or to SARS-CoV-2, and then to try to prevent them from actually getting the infection. And then studies 2 and 3 were hydroxychloroquine or hydroxychloroquine plus azithromycin versus placebo for the early treatment of COVID-19. And then the third study we added in after we did that study, we decided to, they also decided to look at Kaletra or leponavir and ritonavir combination versus placebo. And that was for early treatment of COVID-19. So what do you do when you don't have much preliminary data and you don't really know how you're going to do this? So they used an adaptive design. And so normally when you do a study, you go from design the study, you conduct the study, and then you look at you analyze the data. In this situation, it was more of an iterative process. You design the study, you conduct the study, you review it. So the data safety and monitoring board were extremely important, as they always are, but this was really, really important that they review it and then adapt the study as needed and then conduct it and continue in this cycle until you get the methods that you need, and then eventually you analyze the data. So you're constantly, the sample size calculation may be refined. Sometimes you don't know what's the perfect outcome that you're looking at. When is it the time to abandon the study and say, this is not working? And do you change allocation ratio? Maybe you're getting more, maybe you should put more people on study drug compared to control, and on all these things. And then stopping rules for success or futility, as you would in any study, but sometimes they change because the DSMB and the scientific group decide that they change. So, of course, all these studies had to be published a priori. Harder to publish a responsive design because sometimes you're saying it could be this or this or this. And so, but you definitely want to make sure that that's published so that the scientific community can look at your methods and make sure that they're accurate. As I mentioned, Data Safety and Monitoring Board is super, super important. And they we met with them very frequently in both of these studies. So this study, the PEP study, was in about 12 different sites in the United States. And so when Ruan called me up, I knew her from the HIV world, and she called me up, she said, would you be interested? Actually, it was Connie Kellum who called me up. She said, would you be interested in doing the study? I'm like, heck, I can't do anything because all my other studies that I'm working on are shut down now. So sure, I'll divert my staff to go do this. And so, the protocol, they were developing the protocol. So I'm not used to doing that kind of study, but we definitely said we're game. So we did. And so from the time that they conceived the idea in March 8th to the time that they got activated, their very first patient was about almost a little less than 4 weeks, 3 weeks. So that was pretty astounding. And they called me up in the very beginning of April, and they activated us in April 20th. And in between that, I had a little week-long hospital stay too. So it was crazy busy. Anyway, we went in and we did it, and then we started, and you can see that we actually ended up finalizing the studies, both of the studies, around August. So as you know, this was, you hardly ever, I don't think in my life I've ever seen studies done this quickly. So what are some of the conundrums? Well, certainly, how do you access subjects when the country was completely shut down? So we're used to doing randomized trials in the country, in a CATS environment or in the hospital environment. I do most of my studies in the community, but the community couldn't do it in the community. So they had to do a remote design. And then how do you assure patient safety? So for example, hydroxychloroquine, which is known to elongate the QT wave in an EKG, how do you monitor? We're used to giving them EKGs, so that's another problem. How do you get how do you get personnel for a study when it's that rapid? It takes sometimes, to get people hired, it can take a month, sometimes 2 months. So getting people, so I happen to have a staff waiting, and that was great, and I was able to bring them on. And also there were some students that I was able to bring on really rapidly, so that was another thing. And how do you source materials? Materials were very difficult to get. We couldn't get swabs, we couldn't get masks. Even the placebo that they chose, which was vitamin C, they couldn't get that. They had to go from store to store to store to buy as many bottles of vitamin C as they possibly could. It's not like you could just get it online like you're used to. So sourcing materials for it was very difficult. And then how to get things through the IRB rapidly. Well, I'll say that most IRBs realized that COVID was an international crisis. And so most IRBs, and our Tulane IRB was wonderful and really helped get these things through very quickly. And then how do you and then information is coming left and right all the time. You have to I've never read the literature so constantly and so aggressively to understand what's going on with these studies, because you certainly didn't want to continue on with the study if you found other studies or a pattern that wasn't going to work. And then what do you do? Mostly, what do you do when your study becomes political? It's, and that's, I think, the thing that made this study, made me get so many gray hairs, and my co-investigators get so many gray hairs. So as I said, fortunately, everybody knows Zoom. I had never used Zoom before COVID, and now Zoom is, my whole life is on Zoom. And so these are my great folks that were working on my Check-It study, which was the community-based study to look at chlamydia, and we just diverted them to this study very rapidly. And so, we just use Zoom. And then so we got the staff that way. And then remote enrollment, how do you do that? How do you recruit people? So we had a very robust social media, which actually worked in this population. It's not working for our younger population for my other study, which is a chlamydia study, but it worked very well for the older population, particularly Facebook. It worked very well for a while, and I'll tell you what the caveat was. So we had a very robust social media advertisement. We used couriers to drop off materials, and then we started shipping things to people. So when we started just locally here in New Orleans, and then we started to take on more and more states. Like we went from New Orleans to Louisiana, then we started taking on Florida, then we started taking on Texas. So and in that situation, we couldn't do anything other than do social media. So we did that. And then you can see to do the monitoring of the electrocardiogram, this little device was really helpful. It's a home device, about $150. People put their thumbs on the two little gray portions of it, and it does a readout of their EKG. And so that readout would then electronically be sent to people to cardiologists in the Mayo Clinic, and they actually read the electrocardiograms for us to tell us that there was a problem. And I think there also was a little bit of an intelligent, artificial intelligence that would tell us immediately if it was a problem, and then the cardiologist would read it later. And we also, of course, had to do telemedicine. So that's where a lot of the ID docs from Dr. Mushatt's group helped us by doing the telemedicine. So my staff, who were more MPH type people or public health people, would do the consenting process, get everything all lined up, and then they patch them over to the docs who would do the telemedicine to make sure that they were eligible for the study, that if it was for PEP, that they actually had a credible exposure, that the person was truly infected, and then their family members or people that they lived with would be enrolled, and they randomized the whole household to either arm. So like I said, we had, for PEP, we used 400 milligrams of hydroxychloroquine twice a day on day 1, followed by 200 milligrams twice a day on day 2 through 5, and then versus 500 milligrams of vitamin C. And vitamin C, very imperfect placebo, because they had to rapidly get a placebo, and they couldn't configure. Normally you try to make a placebo that looks like the medication, tastes like the medication, so that the person will be completely blinded. They have no idea if they have the medication or not. Hydroxychloroquine and vitamin C look kind of alike. They both are bitter. So maybe some people could have figured out that they were on vitamin C, but that was as close as they could get in that kind of chaotic situation. And then the treatment, it was 400 milligrams of hydroxychloroquine plus placebo, or 400 milligrams of hydroxychloroquine plus 250 milligrams of azithromycin, or placebo. And they actually gave vitamin C and folic acid in the case of placebo, because in treatment they were taking 2 meds. So they wanted to make sure that they were also taking 2 meds so that they would be blinded. And the same thing happened for Kaletra. They mimicked what they did with Kaletra. Kaletra had a loading dose, and then they did a more maintenance dose for 13 days after versus placebo. So the inclusion was randomized 1-to-1 or 1-1-1 if there were the 3 different arms for the treatment, blinded, and placebo-controlled. PEP, persons who were exposed to someone who tested positive in the last 72 hours. So we also did enroll the index patient to get a nasal swab and see if they actually were infected, or if they just the provider felt that it was credible exposure, and they had, and even that the exposure changed. So at the beginning they had to have a prolonged exposure for like 24 hours, and then that changed to 15 minutes over a 24-hour period. So even that changed. And then we followed them for 28 days using intensive safety monitoring, such as the EKG in the case of treatment. We also took nasal swabs every day, and so the patients mailed those back to us. We took blood spots as well to examine adherence. So the patient themselves took a lancet and poked themselves, put it on a dry blood spot, and then shipped it back to UW. And then we also gave them compensation, which was usually a Amazon gift card, I believe. And then in the PEP study, the outcomes were, did they have an infection of SARS-CoV-2? And in the treatment, it was, did it reduce hospitalization, death, or reduction in symptoms? So you can see that in the roller coaster of infection, that it kept going up and down and up and down, but really there was a huge burst of infection in the summertime. And so when we were trying to get people on, well, I'll talk about that in just a second, but you could see that everybody had a little bit of a different curve. So this is our website. So we use this mostly. People would go here to sign up for the study. They would find out about us on social media, and then they would come here to sign up in the study. Our staff would get that information and then call them up and engage them in the study. And then the treatment had a similar thing, but just a different website. So we know that there were several different things that happened in the course of this study. There were several studies that came in, some saying hydroxychloroquine is harmful, some saying hydroxychloroquine looks promising, some saying all sorts of things. So there was, over the course of these maybe 8 months, we had a lot of ups and downs. So the first down, or sort of, I'm not sure if it was up or down, but there's a confusing message. So both Donald Trump and Elon Musk declared that hydroxychloroquine should be used, and it's wonderful, and it's going to prevent all problems with COVID. And so when they did that, people started buying it off the shelf left and right. So you have trouble now with equipoise, because there's some people in the community that believe these two influencers. And so they would say then it would be tough to actually get anybody to go on the study, because either it sort of you fell into political camps. So if you were in a red person, you would say, yeah, I want to go in the study, but I want to make sure I get on hydroxychloroquine. If you were a blue person, just the opposite, you did not want to go on, and you only wanted to you didn't want to go in the study at all, basically. So, and then the FDA authorized, because of a lot of pressure, they authorized emergency use of hydroxychloroquine. And so it became very widespread. Again, that made it more and more difficult to establish this equipoise. Now, we scientists knew that there was equipoise, but the lay community felt that hydroxychloroquine was, like I said, if you were a red person, you believed it was the way to go. And then after Trump's statement, hydroxychloroquine started to get impossible to get for people who really needed it, like people who had lupus and arthritis. And so there was a shortage of this. And that also put some more venom into anti-hydroxychloroquine people, because they felt, well, that's just horrible. You're taking it away from people that we know for whom this medicine works. And so that's really unfair. And then there was a large study that came about called the SurgiSphere study that found that actually hydroxychloroquine increased mortality for those receiving hydroxychloroquine. Now this study, and so when they said that, we were very worried, and so we started to really investigate our safety data. And then about a week later, it was retracted. And so it was retracted because I still don't know, and Dr. Mushatt and I were talking about where I'm not really sure if they if there's any resolution to that. Were they cooking their books, or was it just an honest mistake and they were just maybe not as careful with their data as they should be? So I'm not really certain what happened there, but I know that was, so we were, we're like, should we stop the study? And then we said, no, we shouldn't, because they retracted it. Then there was a Brazilian study that came out, and it didn't say that there was no more benefit. It didn't say that it was more harmful, but it just simply found no benefit. But that actually that study was quite small. So we figured that, well, maybe there is some kind of just power issue with that study. So we continued on. And then there was some other large studies and that said, but the media, in their mind, depending on which media you were listening to, it was either hydroxychloroquine was working or it wasn't working. So they didn't care about the science of it. They didn't care that the randomized trials hadn't been done. They didn't care that the scientists hadn't had enough time to really scrutinize those randomized trials. But they, in the court of public opinion, it was decided. So then a Brazilian trial came and found excess risk. And so, but if you look at that, they gave a much higher dose than was normally given in any hospitalization situation. So that also, we didn't find that to be credible. So we carried on and continued on with our study, despite, so I just have to say I had a Facebook page, and I had to get rid of my Facebook page because I had so many bots coming at me and venom and people saying just terrible things about me because I was involved in this hydroxychloroquine study. So some of my colleagues who were on the study decided to write an editorial, and we did, talking about taking a stand against politicization of medical research and how swinging the pendulum poses a hazard to clinical trials. And so Anna Burstein from New York took the lead on this, and we were just talking about, how can you do good science when you're up against really intense political pressure? So then there was another very large study that came out, the VA study, and which was not randomized, but the media was portraying it as if it were a randomized trial and saying, this is it, definitive, hydroxychloroquine doesn't work. And so we were saying, not definitive, it's a natural history study, it's not a randomized trial. So while the evidence was sort of mounting, it wasn't definitive yet. Then there was a large observational study that showed a reduction in mortality. So then we're saying, wow, maybe there is some benefit to this. So again, we just went up and down and up and down. And then finally, FDA eventually said, you can't use hydroxychloroquine outside of a hospital setting or clinical trial. So eventually some of the people that were using hydroxychloroquine stopped using it, and the lupus people and the rheumatoid arthritis people could finally get their medicine back. And so FDA eventually, after these studies started mounting, they revoked the emergency use of hydroxychloroquine, which was, again, not for clinical trials or use in, it was for the use outside of a clinical trial. So that was revoked. And then you had groups of even some physicians themselves, and this is they're called American Frontline Doctors, and they were, even despite all of this, they were saying no, hydroxychloroquine can prevent, can treat COVID, and they were just saying that, but they really didn't have the science to make that statement. So our lifeline to getting a hold of people was Facebook, and mostly Facebook. And so we would advertise on Facebook, and we got lots of people signing up. And then all of a sudden, people started to boycott. This is right around the time of Black Lives Matter and all sorts of things that were going on simultaneous to the pandemic. And there was a call to boycott Facebook because they were not allowed, they were allowing hate groups to post on their platform. So because UW is a progressive, and we're progressive here at Tulane, and we said, how can we continue and not boycott? So we had to boycott Facebook. And so that slowed our study down more. We couldn't get the people that we needed to get on the study. And that was really our only lifeline to getting people, is to use Facebook. And we pivoted to, so Facebook and is affiliated with Instagram. So we couldn't use Instagram either, but we could use Twitter. So we tried Twitter, but it just wasn't the same. It's not the same population. Facebook seemed to be the way. So we had to follow in line. And so when we finally, so that boycott went over and we got to slow down, but what we started to do is quite aggressively, and it's a little bit sneaky, is we started to look in states that were red and had high prevalence of COVID. We started to advertise there more aggressively because we knew we could get people on the study more. And that worked. I'm not proud of it, but it worked. And it's maybe one way, you know, because if you, they were having trouble in New York getting people on the study. So we you know, advertised heavily in Kentucky and places like that. So this study came out in December of 2020. So that's right after we had finished our study. And this isn't even comprehensive of all the studies, but just taking a look at this meta-analysis, you can really get a feel for the fact that it's really flat. Hydroxychloroquine, not very helpful for any of the outcomes they looked at. This one was specifically for, I didn't put what it was, but I think it was for death and for amelioration of symptoms. So the status of the study, PEP stopped because they reached the endpoint. And so you can see that's our publication there. They reached the endpoint, and the endpoint was, did people who were exposed to SARS-CoV-2 or COVID-19, did they get infected? And then hydroxychloroquine and azithromycin portion of the treatment study, that was stopped for futility. We got enough patients in the study, and it really didn't look like there was any reason to continue. It looked flat, and we weren't going to get anything. And then Calitra, we really only enrolled about 30 to 40 people in the study from our site, and then they stopped that also for futility. So so here's just what the data look like for the hydroxychloroquine in the PEP study. As you can see that it did not, hydroxychloroquine did not have any effect on preventing infection in incredibly exposed individuals. So you can see the dark line is the hydroxychloroquine group, and the dotted line is the control group. So really they cross over one another, and it really didn't show any, you know, this wasn't statistically different. It looks like it's the hydroxychloroquine group was worse, but actually that's really statistically insignificant. And then in the treatment, we were looking at two different outcomes: incidence of symptom resolution and also incidence of clearance, because that was two things. Now, those are different outcomes than what we had before. The original study was designed for death and hospitalization, but because these were all outpatient clinics, outpatients when we started them on the study. So we wanted to prevent death and we wanted to prevent hospitalization. We didn't get enough of those outcomes. So that's why they went to these outcomes, which was symptom resolution and clearance, which could, if they did clear faster, that would have great public health significance. And in fact, when you look at this, the arms, the dark arm is the placebo, the blue arm is hydroxychloroquine, and the orange arm is hydroxychloroquine and azithromycin. And you can see they're just on top of one another, really no difference at all. And the same thing for clearance of the infection. And so that came from the nasal swabs that they were doing every day. And so we had about 680 in the post-exposure prophylaxis study, and about, I think it was about 400 or so in the treatment study. So our other study, in the meantime, so we were finished with those studies. So my colleague and friend, Sue Ellen Abdelian, who is the head of the ATN Adult Clinical or Adolescent Trial Network, she is affiliated with this group called the CoVPN, which is a group, an affiliate of all sorts of different sites where they run randomized trials, or they run trials or run clinical studies. And so she said, do you want to do the study? I don't have time. So I said, well, I got all these people. I don't want them to lose their jobs. So we decided to do that. So this is the COMPASS study, and it's fun. Again, this one is funded by National Institute of Health. And the whole goal of this study is to go to the population in a randomized manner and try to figure out what the true prevalence, or as close as we can get to the true prevalence of active infection and post and historical infection. So what we did was to survey the whole Orleans and Jefferson Parish and carve out, gerrymander an area that had to be 150,000 people. And then we picked out spots that we thought would be good to get them. And we did ethnographic studies at the spots. We sent people out to count how many people came by and what was their demographics. And then the central, it's Family Health International, that's the data people, and they randomize which site we'll go to each day. And so when we go to the sites, we interview them with about a 25-minute survey. They get a nasal swab. They actually do it themselves. It's mid-turbinate swab. And then they get a blood draw. And the blood draw is for antibody studies. And then the blood draw is shipped off to FHI, and the actual nasal swabs are done at Quest, and we're actually going to be doing them here in-house starting hopefully soon. And we randomly select, and then we're going to selected areas in the community and also nursing homes and a couple of clinics. So we're trying to get a range all the way from 2 years all the way to as old as possible. No, there's no limit on the age. So they're doing the nasal swab antibody testing questionnaire, and they get $25 of compensation. And we are actually getting a pretty good outcome. We've gotten in about 2.5, almost 3 weeks, we've gotten 500 people. And I say that's pretty dramatic because we had several days where it was just raining cats and dogs, or it was so cold we couldn't go out. And so that was actually, I think, pretty good. Our goal is to get 50 a day, and we're getting closer to 30 a day, but we're still ramping up. We have some add-on studies that we're going to be looking at variants. Also working with Bob Gary and some other people, I think Ron Veazey's on here, to potentially look at antibodies to other coronaviruses, common coronaviruses, to see how that would influence your infection rates and also influence your severity of infection. So it's not without issues. So again, hiring staff, we've been able to hire staff, that's not a problem. We can't get any Spanish speaking folks because right now with the vaccines, anybody who is an interpreter or can speak Spanish and does research, they're being co-opted by the vaccine people, and they get paid $55 an hour, which is nearly impossible for us to match. The weather is a big problem. We have these pop-up tents, as you saw, that was the pop-up tent. And the tents often fly away when there's any kind of wind. And no matter how much we weight them down, we have like our biggest guys holding it down and still it flies away. We had thought at first, we thought, well, maybe we should have a mobile van, but before people were vaccinated, and even still, you wouldn't want to bring people in a van with the potential that, you could spread the infection in the van. So we really wanted to do this outside. I feel really bad for the people up in Chicago and New York that are in the study because they had, the huge winter storm. So it's feast or famine too with patients. So for example, when we go to the zoo, and we were trying to get mostly kids at the zoo, and that's a complete bust, because who wants to bring their kid to the zoo, have fun, and then ask your kid to get poked on the way out? So that's a big problem. We are going to go to Children's Hospital. Thank you, Stacy Drury, for helping us with that. And we're trying to get more children. We're really good with folks in the mid-range. We're not so good with older people and the very young people. But this is where we went to Leon C. Simon, and I think it is Washington, so A.L. Davis Park. So that particular day, because of the winter storm, we couldn't get our incentives, our gift cards. And so we normally give gift cards. So I just went to the bank and got money. And so we were passing out money. So they got wind that we were passing out money. And then we had a line of like 50 people lining up. So we had to give them numbers and say, the first 10, you wait here, and the rest of you need to leave and come back in an hour. So if you want, 0 to 10, come now. 10 to 20, come in an hour, et cetera, all the way through. And, we've had some altercations, not too bad. We did have, people, we have difficulty sometimes getting veins on people who are injection drug users, because we're going to the community. So this will be different than the Ochsner study that was done, a very well-designed study, very esteemed colleagues. They had people sign up, and so we're going to the community, and also that was in the very beginning of the epidemic, and so now we're much more mature in this epidemic, and we're going to the population. So we are right now, and we wish we had a little bit more. We have about 38% African American, and we're still trying to get more and more. And so now we're just we're going to go to nursing homes to get some older folks, and then Children's Hospital, some of the clinics and daycares to get younger folks. So. And then if we add on the variant study, we do want to see what are the circulating variants in the community. And so that's some of the things that we're going to be working with Dr. Di Tian, who will be hopefully doing that. And then if we can do the other coronavirus thing, we don't have funding for that yet, but we're hoping that we'll be able to. So we're going to bank those bloods to see in the future, if we get some money to do that, then we'll be able to examine if common cold will protect you or make it worse for you to have coronavirus. So just wanted to certainly thank my colleagues, Ruanne Barnabas and Christine Johnson, for inviting us to do this study. It was a blessing and a curse all at once, but it was great. And of course, thanks to Dr. Al Luke and John Dwyer for serving as co-PIs on this studies. Sue Ellen Abdalian, Dr. Sue Ellen Abdalian, for helping guide us to the COMPASS study. And then my program manager, who's just astounding. She's running 4 studies at once and helping me with all of these. And just to source it, like her room, every time you go in there, her room, you can't see her because there's boxes of stuff all over the place, because it requires so much equipment to do these studies in the field. And, we are constantly calling up colleagues. Can we borrow some tourniquets? Do you have any butterflies? Do you have any red tops? Because it's really hard to get stuff these days. And also the fact that we have to get them so rapidly. And we have really great study coordinators and all the doctors, the additional doctors, ID docs, who thankfully helped us out during this time. And, now they're back to normal, so I'm sure they couldn't do this, but some of them, you couldn't really do much because of COVID. So we were really thankful for their help doing the telemedicine. And then the amazing dedicated staff who spent all sorts of hours doing this. And then all of my MPH students who served as research assistants. So that was more, I like to put this up because science is like magic, but it is real. And so the thing is that when politics gets involved, study, it's hard enough to do study design. It's hard enough to implement a study, but then when you have politics on top of it, it makes it even more challenging. So thanks for your attention. Appreciate it. Not sure if, there's Paul Fidel. Hi, Paul. Not sure if there's any questions, but this was more just to describe kind of a moment in time and the difficulties of doing these kinds of studies under such duress.
Well, I do have a question, actually.
Yeah.
That was really good. And, I appreciate all the honesty in terms of doing studies like this. And, we're having our own troubles trying to do COVID-related trials as well. What did you, how was it dealing with the institutional approvals, with either Tulane or otherwise? I mean, everything that you change in a minute has to be approved by the IRB and so forth.
Right.
And then secondly, I'm sort of familiar enough with Facebook and so forth. Did you do your own study Facebook page, or was that, a university site Facebook post, or how did you do that?
Really excellent questions. Thank you so much, Paul, for those questions. So first, we use commercial IRBs. So UW used WERB, and Compass is using a different one. So they had commercial IRBs, which actually can go much faster. They're expensive, but they go much faster. And we have agreement with our IRB. They acknowledge, basically. I mean, you still have to put everything through, but also because of COVID, that sped up things greatly, having the commercial IRB. So that's one thing. So Facebook, we use their website. We didn't develop our own website, so we still use their website, but we did, they advertised for us. So they said, we just divvied up the whole country, and I think we had like 13 states. And so they would send out advertisements for the profile people that they wanted, the age range that they wanted, and they would do it with the frequency they want. And then we actually, in our budget, we had some money for Facebook. So we did it more targeted too. So if we knew, like I mentioned, and like I said, it's a little sneaky, but we knew that Tennessee, parts of Louisiana, a little more conservative, and wouldn't have maybe the issue with hydroxychloroquine that some other places did. So we would amp up and put more advertisement in those areas. But we used the same universal website. So people went there to sign up, and then that information, when they signed up for Louisiana, or when they signed up, they programmed it so that it would go immediately to us. So we had, I think, Florida, we had Texas, we had Alabama, Mississippi, Tennessee, and then randomly like South Dakota. I don't know why we had that, but we did. And so so we had more states than that, but so that's how we did that.
So this is not a loaded question, but if you were to do it again, what would you do differently?
I think that UW did a great job of figuring this out in such a short period of time. The two PI, particularly Ruann Barnabas and her team, Connie Kellum and some other people, they were just brilliant in how they determined how to do this. And then the treatment study kind of just mirrored what was going on. And Christine Johnson is also brilliant. I don't know that I would do anything differently, except I might not have done it. I mean, you know what? I mean, it didn't really benefit me that much. I don't need more publications. It didn't really benefit me that much because I wasn't the overall PI. I did it more to help my staff because I didn't want to furlough them. And they were there and they were trained. And at that point, when we took on both studies, I had equipoise. I had no idea if hydroxychloroquine would work until then. All of a sudden, very rapidly, it became more and more political. And, like I said, I had to shut down my Facebook and all my social media accounts. And I had to get out of they even came into my WhatsApp. So I had to shut that down. And we were getting like hate calls from people on it. And New York got it the worst. That they really got it bad. So that's not really an answer to your question. I don't know what I would have done differently. I think that was about as good as you could have done in that environment with social media. In fact, I am now using some of the techniques. We're publishing the techniques that's coming out probably pretty soon. I'm starting to apply those techniques to my chlamydia study, where we were in the field and now we can't be in the field because the HBCUs are closed and then our recreation centers are closed and the kids aren't in school. Now that may change. We might be able to get back there in fall, but for right now it's closed. So we started to move towards these remote recruitments. And so I think it's actually, if anything, I think that's the wave. And I don't think we're going to get away from Zoom meetings. I don't think it's going to be 24/7 like it is now. But I think we're going to continue to do Zoom meetings, and I think people are going to continue to do remote recruitment, and people are going to continue to use social media to recruit. They were using social media before to recruit, but I think it's going to be used more. I don't think it answered, but yeah,
no, that's fine.
I wouldn't change anything really.
I appreciate all your comments. It's great.
Thanks for the question.
Other questions? I think you answered some of the questions I was going to come up with, Patty. Anybody else?
So Dave, you just did a talk just like this. What else did you add that I didn't add?
Well, I sent you my PowerPoint.
Oh, you did?
Yeah, I sent it to you, and actually it was quite similar in many respects.
We
Yeah.
could have just shared and I wouldn't have spent hours getting this together.
Yeah, I mean, I just sort of, I emphasize things for the, basic, the juniors, physician scientists, things, basic tenets like in vitro doesn't always predict in vivo.
No.
And I think that's what we're seeing. I mean, look at how many repurposed drugs, ivermectin, famotidine, they look good sometimes in vitro, but they don't work in humans. And it may have to do with the dosing, there's so many, does it get inside the cells? There's many different things, but it's a very important lesson. I think the other important lesson is, the sort of primacy of randomized controlled trials. We saw, with the hormone replacement therapy, with the antiarrhythmics in the 80s, all the retrospective studies showed that intervention would work. But when you subjected them to randomized controlled trials, not only did they not work, but they actually sometimes increased complications and increased mortality. So again, we have to be very careful with observational and retrospective studies.
I have to tell you, I can't tell you how many times I would read an article of a retrospective historical cohort study, and they interpret it as if it were a randomized trial. And I remembered the CNN lady, and I looked her up and I said, and I wrote her a letter, and I'm like, you have an MPH from Johns Hopkins University. That's a very credible university. I'm surprised that you would interpret this retrospective cohort study as if it were a randomized trial. Of course, I got nothing back from her. She didn't answer me. But at least it was cathartic for me to be able to say that.
Absolutely, yeah. So I mean, they give us ideas and things, but they don't really.
But that's what you have to do. You have to go in vitro, animal, to human, and so that doesn't always work. But there's no other way.
Absolutely.
To do it for you to be able to.
And then and I guess my maybe a question for you is, obviously in the future, if and when, and I'm sure this will happen again, we'll have another epidemic and we won't have time to leisurely design our studies and get them approved. It's going to be another hectic, chaotic effort. But, assuming at least that the leadership in this country is willing to listen to scientists, what can we do differently? How can we safeguard against the politicization and, reliance on things like Twitter for our information? I mean, I know it's a huge question, but is there anything that scientists can do so that we don't make some of the same?
I mean, you just keep talking and you just keep writing. And like I was writing editorials to the Times Picayune and Advocate and stuff like that, just trying to, in other areas, just to try to get. But who reads that? I mean, fewer people read that than. And people listen to their feelings. They don't listen to rational. So I think it's going to take kind of a shift in how people consume information and distill it and synthesize it. And we're not going to have. I mean, I've heard people say it's going to take another generation for us to get out of this kind of disinformation that's going on here right now.
Right.
It's gotten way better, of course. But still it's there. We have the vaccine deniers and that's going to be a problem. Yep.
So it's going to, I think you're right. I think it's going to take, it may literally take a generation or two to see what happens when you get your information from Twitter and you just see one side or maybe one tiny component of the overall story. And so, I mean, and this, I think this needs to be taught in schools. I think, lay people we need to educate people better, or perhaps about how science works and the pitfalls in how the media will take things and blow it out of proportion. And of course, it doesn't help that there's probably Russian bots and other things out there that are,
there's Russian bots.
they're out there that are,
There's somebody that kept taking my colleague Anna Burstein from New York and taking any picture she had on her Facebook and making her with orange hair so she would look like Trump.
Oh dear. Yeah, it's just too easy now, isn't it? It's
too easy.
It's just a free for all, and I think that, maybe there'll be a reaction to this, and we'll go back a little bit, or well, we'll have better technology, but I don't know what the answer is. But
I
anyway,
think
that
also standing strong as a scientist,
Yeah.
saying, no, I'm not going to be distracted by people's distractions. I'm going to pay attention to the science and go through the scientific process. And that's the only way you can really do it.
right, and that's what Tony Fauci has shown us, that you need a steady hand, and you can't waver back. I mean, you can't go back and forth. You can change your mind, and we should.
Oh,
There's
yeah.
nothing wrong with changing our mind when based on good information, and that's something we should encourage. On the other hand, I think he's done a great job of towing a steady line, and being calm and measured and thoughtful about it. And that's what we need is a lot more of that as we go forward. And hopefully people will see that good science has led to some of the breakthroughs, and will continue to do so with the vaccines. I mean, that's based on really phenomenal science and technology. It's been very gratifying, but we still have a long way to go. Any other questions from the participants? Any parting words, Patty?
Just keep calm and carry on and do the science, and you'll be good. And thank you so much for attending. Appreciate it.
Well, thank you, Patty, for a phenomenal overview of science during the COVID pandemic, the ups and downs, really extraordinary. And thank you for the attendees for participating this afternoon. I just want to let you know that there will be a recording of today's session that will be available in a few days, and will be shared via the CATS listserv and posted to the CATS YouTube channel. So the next Chronicle Seminar for CATS will be held on Thursday, March 25th at 4 p.m. Please join us for talks by Dr. Chelsea Crack from the Pennington Center in Baton Rouge, and from our own Dr. Elizabeth Norton, PhD from the Department of Microbiology and Immunology at the School of Medicine. We also welcome more speakers for this. So if you know of anybody, or you yourself would like to be a speaker, please contact the COVID team here, or the CATS team, at info@lacats.org. And with that, if there are no other announcements, are there any from Megan or anybody else?
No, just a lot of gratitude. This was really tremendous. Thank you so much.
Yeah,
Dr.
I
Kissinger.
think it was really well received and very provocative, and great work to everybody who stuck it out and saw these things through to the end. Well, with that, I guess it's 5 o'clock. We'll wrap it up. Again, thank you, Dr. Kissinger, and participants for a great hour. Everybody get your vaccines, be safe, and be well.
Bye, Lisa. Bye. Thank you.
Yes.
Bye-bye.
Thanks. Thank you, Dr. Mushatt. You did great.
Thank you.